Just close when you do it.
All right, we're ready.
Johnny.
Yes,
We'll call the meeting to order. Was the meeting properly noticed?
yes, it was.
Roll call.
Bob Grabowski,
Yes.
Rick Pease,
Here.
Marge Edwards,
Here.
Gordy Carlson,
Yes.
Terry Harvey Beaversdorf,
Yes,
Deb Johnson Shoe.
Yeah.
Dr. Richard Long,
Yes.
Josh Pozdralski. He's not in attendance.
Becky.
Oh, did I say that? Becky? Pease? She's not here.
Under the agenda, we will move 9C up to 2A. I have an approval of the agenda.
So. Second.
Motion by Bob, second by Gordy, all in favor?
Aye.
I,
Opposed? Opposed? Motion carried.
Isn't it open?
I assume you've all read the minutes from the October meeting.
Yes.
Motion to approve,
So moved. Second.
motion by Rick P, second by Bob Grabarski. All in favor?
Aye.
Opposed? Motion carried, minutes approved. Any public participation,
We have none signed up.
correspondence?
We do have correspondence. Marge received a letter from the Department of Health Services congratulating Adams County Health and Human Services for demonstrating the infrastructure and program capacity to be certified as a level 3 health department. You remember Cody talked about that last month and we were waiting for informal notification from the state. So they have let us know that we met the requirements and will retain our additional funding to stay a level 3.
Very good. Tell Cody, thank you. Veteran Service Office, Rick, are you on?
I'm here, Marge. Little under
Okay,
the weather. Yeah, hope you can hear me. I'm a little under the weather, so. Can you hear me all right?
yes, we can.
Okay. All right, for the month of October, we met with 36 clients. I had 201 phone calls and faxes, 285 electronic transactions, 4 outreach appointments. And then we had a busy day on the 11th. We had the Vision 12 mental health Zoom meeting with Madison VA. Then we had the Adams County Veterans Commission quarterly meeting, and the notes are attached for that meeting. And then we had Scott went to the Adams County Mental Health Community Action Team. And then with the help of Bonnie from ADRC, Bonnie Billington, we got one of our veterans down for the honor flight on the 10th of October. And then I went down and picked him up on the 12th, brought him back home from Madison. Without her help, we would have never got that accomplished. And then the 17th to the 21st, we had our Wisconsin County Veteran Service Officers Association Fall Conference accreditation up in Wisconsin Rapids. So Scott and I are accredited so we can hang on to our jobs for another 6 months. Other than that, you have any questions on my report? Oh, and then Marge, we did get all the bulbs out for the Veterans Green Light porch light thing.
Right?
Yep.
Good.
Yep. And I could have done that without Bill and Tabitha.
I'm sorry, I didn't catch that.
I said Bill and Tabitha did a lot of the legwork on that. Bill got the light bulbs and then he got them around to all the county buildings. It's pretty sharp, the pictures he took with the community center all lit up in green.
Okay, thank you.
Yep, and then just back to are in service on Veterans Day. The silent raffle, Carrie sent me an email today. They collected $1,167 for the Needy Veterans Fund. So that was a good thing for Mother County employees to donate to that, and I really appreciate it.
Yes, that's very good. Thank you for sharing.
Yes.
Any questions?
Rick, this might be jumping ahead, but Veterans Service Commission report, when I read that. Their attendance, was there only 2 people there? Do you know?
For what? Yeah, pull that report up for me. Is that in front of me?
Cause like Colburn was making motions and one other one second.
No, there's we had 4 members there. We had
Okay.
Scott, we had Scott, then Wilfred Reich, Edward Heidemann, and William Arnold.
Okay,
And then I was there as a recorder.
how many members can come or how many members are actually?
Anybody? Yeah, we have 5, with Scott being the president, but we have to have, I think, 4 to have a quorum or something like that. So, yeah.
What is this group and what is their objectives?
It's by law, county statute, Wisconsin, just like the county veteran service officers, we have to have a commission that oversee that. They have to have quarterly meetings. And they just go over with our help from the county veteran service officer. If I have to approve over $500 for a needy veteran, they have to vote on it. And they help set up, other programs, and they meet with all the other service organizations in Adams County.
Okay, thank you. Are
You're
there
welcome.
any other questions? Thank you, and I hope you get feeling better.
I hope so too. Cold weekend.
It's Monday, the weekend's over.
Yeah. You sound like my drill sergeant. You guys have a good evening.
You too. Okay. Moving on. Jess?
Hello, everybody.
Hi.
I'll stand. So some of you know who I am, but I'm Jess Stevens. I'm the psychiatric mental health nurse practitioner that serves Adams County Health and Human Services. Just as a little recap, I contract here 40 hours a week. I contract 1 day a week with the Menominee Tribal Clinic as well. I'm usually there on Wednesdays. And then I have a small private practice in the evenings, 1 night a week. So that's kind of what I do in terms of psychiatry care. I wanted to give you a little bit of a snapshot of what it is we're currently doing within the program. You get some of the basic numbers every month in the report, but I did break those down a little further. So right now we have 242 psychiatry clients. 191 of them are adults and 51 are under the age of 18. Okay, we see down to age 5 at this time. And that's pretty much the youngest that we'll see at this point of the game. We also have a medication administration program. We have 65 folks on that at this time. 14 of those 65 get oral medication, meaning they come in daily, every 2 weeks, once a month, that kind of thing. Of those, 2 of them are under the age of 18. And then we have 51 clients on long-acting antipsychotic medication. And of those, 7 are under the age of 18. Okay. So those really help us keep folks stable and that kind of thing. I wanted to let you know kind of where we are in the referral process and how long it takes us to get clients in. We really serve very high acuity clients here. I don't typically get referrals for clients with straight depression. Maybe it's their first depressive episode or they're anxious. Those are not the clients that we see here. Those folks 9 times out of 10 are being seen by their primary care provider. I get people who've been on 20 medications, aren't stable, those kinds of things. Kids that are tearing apart classrooms because they're diagnoses or their trauma has been so impactful to them, those are the referrals we get here at Adams County, okay? 9 times out of 10, they have tried and failed a number of things. Other providers won't see them for a number of reasons, that kind of thing. From the time we get an accepted referral, the referral meetings happen with the management team every Monday. From the time that acceptance is happening until the time I'm seeing clients, if they take the first available appointment, I can get them in 4 weeks. Roughly, usually every 6 weeks is about what it's looking like. And if there is a crisis, I have a crisis time open at least twice a week where I can get people in within days if we really truly need to do that. I see people at lunch, I come in early and I stay late if that's necessary. I live here in this community and it's important to me and to our team. Just so you kind of have an understanding, let's use Rocha Cree as an example. They have a very brand new provider over there. She's doing really great for a new provider. High acuity people come to me. She will call and refer them back to us. That's pretty common, just in general, so that you kind of have an idea of that. Looking at our local counties around us, Juneau County has a 7-month wait to see psychiatry. Sauk County is 16 months. Paquette Center is 12 months. Marquette County is 4. Wood County is 3. Portage County is 6 months. And Dane County is not accepting any new patients, none. They won't see people at all. And of that list that I just gave you, 2 of those providers will see children at all. So
Where do we stand with that?
we're at between 4 and 6 weeks. So that's really awesome. And where that also matters is I can see clients in 4 to 6 weeks and still see my existing clients in a 4-week recall if I need to, or if I need to switch someone in because the meds aren't working, we can still do that right now, which is really awesome. To give you an idea of the acuity level that we have here, that really high need client load that we have, that 242 greater number, 58 of those are also diagnosed with substance use disorder, okay? Bipolar disorder of any variety, 79 of those 242. This is the one that is really impactful, and I really actually, as a result of this meeting, want to dig into this a little bit more. 46 of that 242 have some sort of psychosis, schizophrenia, schizoaffective disorder, delusional disorder, extreme paranoia to the point that it impacts their day-to-day. That's almost 18%. Normal number that we expect to see in a community is less than 1%. We are at 18. That's a huge issue, right? But on the upside of how well we're doing with that high acuity level of client, out of that 46, 3 are under guardianship in a group home. The rest of them are maintaining independence in the community. That's huge for our cost. It's huge for the quality of life of our community. Really saves us money when those folks are stable, because those folks with bipolar disorder and schizophrenia, they cost the most amount of money to stabilize inpatient and then go back out into the community. So that's important.
Can I ask a question?
Yeah.
You had 3 numbers there, 49.
Yep.
Whatever. Are any of those duplicates within that number?
So great question, because a lot of them are. Clients can have multiple diagnoses. The only 2 that won't bump, okay, would be schizophrenia and bipolar, right? Because that's schizoaffective disorder, okay? So some are like anxiety. 175 clients have a diagnosis of some sort of anxiety. Obviously that overlaps with another one. That's a really awesome question. Major depressive disorder, 113 of the 142 or 242. ADHD is at 99. That is one diagnosis that our local providers will not treat. It's a simple diagnosis to treat, and it's a lot, we're doing a lot of education with them. Because it's an easy diagnosis to diagnose and it's an easy diagnosis to treat. That acuity level, if they just have ADHD, we don't need to see them. Like that, I'm really good at schizophrenia and bipolar, and I can treat ADHD wonderfully, but so can a primary care provider. So we really want to focus within the community that our spots are held for those folks that really kind of cost the county money, and on top of that, also need that really good functional quality of life.
You have that same ADHD Are you getting help from the school district with those type of individuals?
So if they are a school age child, I can actually, I have 3 kiddos in the last 2 months that I've gotten referrals from the counselor at the school. Because she knows that we do a good job treating ADHD, and we've gotten those kids, 2 of the 3 are back in the normal classroom and not having behavioral problems. And I don't need to throw high medication at them. I am simply treating their ADHD, and they are back in the classroom setting and not running in the hallways. So huge improvement. That's just 3 kids as an example, right? A lot of kids also, ADHD is sort of my soapbox, because if we would treat ADHD a lot sooner, kids wouldn't get technically speaking, wouldn't get an oppositional defiant disorder, where they think that they're just truly really working and not listening to the teachers, when truly it's just ADHD and we need to get that under control.
Mind if we ask questions along the way?
Absolutely, shoot.
Mine won't be as good as Rick. But, so who does the when you talk about a 16-month wait or a 4-month wait or whatever?
Yep.
So who diagnoses those patients? And, you know,
They do not get seen in some cases. They are the folks that are out there floating in the community, or let's say Portage County as one example, right? They potentially are paying for inpatient stays over and over and over again because they cannot get those clients in to be seen.
And do you find, I assume depression comes in on this, do you find in the longer waits, more suicides or?
Yeah, so let's just use an example of me. I've been here now 2 years, just about, give or take, providing full-time services. And Dr. Fisher, or the psychiatrist before me, who was my mentor, he is excellent, but he was only here 4 days a month, right? And so from that transition from him 4 days a month to me 4 days a week, the crisis contacts that we've had, I can routinely say that 9 times out of 10, those crisis calls that come into us now are not our existing clients. That side of things has drastically reduced. The people that go inpatient now, not my existing clients, right? So we know that it improves patient outcomes if we can get them seen sooner. We've seen it here. They would totally see it there if they had that opportunity. That's a really great question. Yeah. Actually, I'm getting my doctorate as we speak. So I'll have my doctorate in, like, I don't know, less than a year now, but that is actually the project that I'm going to be doing here in Adams County, is now the crisis calls that we're getting on clients that have never done any services within our program. My goal is to work with them, figure out why they haven't, and then launch a community-based campaign to get people to understand the services we offer here. So we should further reduce suicides in our county. That's the goal.
But using that as your template, doesn't that then will increase the length of seeing people?
Potentially, right? Depending on length of time. So our goal will be to not go longer than 8 weeks. That's my true goal, and we're working to keep that in pace. So that's a really great.
Last month.
Mental disorders, dementia, cognitive decline, that kind of thing. We have about 25 of those, 7 of them are under a guardianship. So that's more likely to be the group that's under a guardianship. So I'm trying to think of anything else. Do you guys have any other questions?
How can we help you?
That's a really good question, I will say.
How long is the list?
Right, yeah, I mean, you could throw more, no, just kidding. So I have two really awesome nurses, and I will say I'm very thankful to the board because when I started here, we only had one and we didn't really have that. And so now we have two, and the nice thing about us having two is Brandon, who handles the med administration part. He actually now goes into the community to give injections and things like that if people can't get here. He'll deliver medications, we'll work with the CCS case managers. So the fact that we're continuing to support that full nursing stuff is really, really important. I think we get most of what we need, of course, continued program filling holes in our staffing that we already have, case managers, things like that, because as you pointed out, the more people we take and the more prevention we do, obviously leads to more clients. What will happen then is, so say I need to hold space for those evals so I can get people in diagnosed and started on medication. What will become the delay then is a follow-up. So instead of 4 weeks, maybe it's 6 weeks for a follow-up. And I count on those nurses and that CCS staff and the therapist to see people in between, be eyes on those patients for me, so that I can make adjustments if we need to, if I can't get them in, kind of thing. So continued support is where it's at for us.
The light just went on, just so you know.
Oh, the little owl eyes are on.
Fantastic.
Okay.
So those are really, really awesome questions.
Corey's been holding back.
Yeah.
He's got,
Every time about you thinking about doing something, you guys bring it up. Got nothing to add.
I will say, the only other thing that I would say is super important, we just had a young man go from jail. He actually ended up in jail in another county, in jail to an inpatient facility that is connected with the jail system, which is called Mendota, right? Mendota Mental Health in Madison. We work really well with the inpatient facilities, and they are vastly important to what we do, especially for those clients that are suicidal when safety is an issue. The wonderful part of inpatient is they get people safe, but the goals are to get these people functional and back into the community where they belong. And that's the most important thing. Inpatient, whether it's SUDS, substance use disorder, or mental health, the goal is to keep people in the community. Inpatient facilities, whether we're talking mental health or substance use, they stabilize, they keep people safe, and they give them the very basic skills for coping. We need people in the community to integrate them back here and work with us. That's really, really important too. We do a pretty good job of communicating with those inpatient providers.
Okay.
So.
Yes, go ahead.
I just want to thank Jess for coming. I think that your presentation was really informational. And I hope it was helpful for you guys to understand some of the programming that we do here. And we are incredibly lucky to have Jess, especially to have her at 40 hours a week.
I guess I
3
didn't
years
realize
ago?
the numbers was that high.
Well, and 3 years ago, we were doing
140 clients. give or take.
140 clients, 40 hours a month of psychiatry. And there were months where we were trying to figure out if we were gonna have any psychiatry.
And no kids. We didn't do any kids at that time.
So to have Jess, and Jess decided to go back to school, and we're very fortunate to have this in our community. And I can't underscore that enough. We were very lucky to have Jess.
It's a pleasure to be here. I live here, so that's important to me. My husband was born and raised here. And our son is a senior, so it's important to me that this community lives and thrives, so.
It's too bad Josh isn't here, because I'm sure he has some really good questions. I hope that he takes time and listens to this, because.
Yeah.
And maybe we can have Jess come back at another time to give another update. Because I think it's important to get that message out there that of what gets served here is really the high acuity,
Mhm.
that there are some very complex cases in our community that we are maintaining.
I think you did mention, and maybe this is good to put on the recording, about schizophrenia and why we don't diagnose young people with schizophrenia. I think that might have come up recently. You and I were kind of discussing that. There is some really awesome research coming out to diagnose kids as young as 12. Right now, we don't do that. we don't really do diagnosis of schizophrenia until they have to have had the symptoms for a certain number of time. It goes through a very stepped process to diagnose according to the manual. And most people have what we call a first break psychosis, and sometimes that's missed for a number of reasons, because it gets put off as drug use or whatever the case is, but that's most common. I've had two kiddos this year, a 16 and a 17-year-old that had a first break psychosis, and it was caught. And they are very well maintained now. And so under the age of 18, it has to be really obvious that they have a psychosis. Those younger kiddos that probably could be diagnosed with schizophrenia, just tell me if this doesn't sound familiar. You know, your 12-year-old withdraws from the family and spends more time in their room. They're not talking to their friends as much anymore. The teacher says they got really quiet in the classroom, those sorts of things. And I don't know if you know any teenager, but that's pretty common stuff, right? So if we miss it, we miss the mark. And get these kiddos on heavy hitting medication, which is what's needed to treat schizophrenia, we can do damage if we've done it wrong. So now, as things stand with diagnosis of schizophrenia, they have to have those hallucinations and things like that for at least 6 months in the absence of a drug or alcohol abuse. That's a different diagnosis. So the kiddos that we've had, the 16 and the 17-year-old were really obvious. And they are now under treatment and doing very well. And we try to catch those young people very early because they have the best chance at functional life. The more breaks a client has with schizophrenia and more symptoms come back, the more brain volume they lose. The brain volume they lose, early onset dementia, things like that. So the sooner we can diagnose these kids that have schizophrenia, because we know that the signs are there, we just don't know enough about the signs yet and what's happening in the brain. And do we MRI every kid out there that might be withdrawing from their family? You know, maybe that happens one day when it's a safe thing, but that's probably what it would take at a young age at this point. So that's something I'm glad that we thought to bring up, just so you guys kind of understand where those diagnoses come from.
I would suggest, if these wait times get longer, we see a justification by you, Kelly, to hire even more people if we have to. 6 weeks is a long time for somebody who really needs help. And even though we're faster than any other county, doesn't mean we're being fast enough. So that's where I said.
That is an excellent, and here's the other thing that I didn't mention is all the time, I have a student with me, a psych NP student going through the program. 9 times out of 10, I'm getting them at their very end. I have one coming that's just starting clinical. But I never don't have a student, and I'm actually booked until August of 23 with students. So there is a very rich pool of potential options out there, because once they're here, they've all liked it. They would love to work here. Because they see how well our team works together and what the options are here. So if that ever did become a need, 100%. I mean, these are people that are working directly with our clients that would potentially want to come back here.
I know it's not cheap. I'm just saying that we have to get out there and really push it if we.
Try and stay ahead of it a little bit, or keep at least level.
Meeting the
with it.
need, right?
Yeah.
Meeting the need. That's the
Well, and
goal.
even breaking that stigma is hard. So when you make that call and you want that help, and then you gotta wait 6 weeks.
Yeah.
Do you get
or 12 months.
any help through Medicaid or private insurance?
I will say, this is kind of the first case scenario, but Medicaid and Medicare are the two insurances that are the easiest to work with in psychiatry, which is kind of surprising considering how it is on the outside world, right? But they are really good with medication approvals, all of that, and approving services. That's huge.
So we can kind of offset a little bit of
small
that,
portion,
a small
yeah.
portion of that.
So thank you. I really appreciate the questions. So,
Thanks, Jess.
yeah, all right.
Thank you.
Have a great night, everybody.
Thank you.
You too.
We logged in.
Oh, no.
Yes, I can.
Be careful, your psychosis. will act up.
Thank you.
I wasn't gonna ask a question tonight, but I did.
We like when you ask questions, because that means you're interested. All right,
Okay. moving forward, the August and September financial reports.
Sure, so Wendy is on to give a quick update. Can she hear us?
Hey.
Ruth?
You have the August and September in your packet, and both of those reports show an end positive balance. I did run an October report this morning, and that too is still running in the black at about 126,000. But I do anticipate November possibly, but pretty sure in December we will start running at a deficit. That is only because the expenses, as we close out the year, we have to make sure we get all the 2022 expenses in and posted, and they tend to come in a lot faster than the revenues because we need to get those expenses in order to claim those revenues. So there will start to be a deficit showing on your reports, but I am not worried that we will come in over budget. I think we will be coming in under. Knock on wood. Any
Does that
questions?
include, I think the last time that we looked at the budget, you guys are going down from a $370,000 budget down to 59,
The fund
deficit.
balance?
Yeah,
and that's
Yeah.
gonna continue?
yes, I think so.
Okay, I just,
We're tracking that way. The only
That's a really good-
real, the things that are unvariable are inpatient. And sometimes those bills come in very, very late, or we'll get costs from last year. And those can sometimes be a little bit of a surprise, but right now we're trending that we will be in the black. Which would be really exciting to be able to say we have no surveillance status.
so you're talking about being in the black, totally not just,
Mhm.
okay, that's great news. Wow.
Okay, but I feel like we're jinxing it.
Yes, yes, please. Knock on some wood.
The other thing that we wanted to highlight, there is a third quarter practical sense revenue report in the budget. Wendy, do you want to go over that real quick?
Yeah, I want to stress that Practical Sense does not use any tax levy. Between the services that they provide to the clients and the revenue that brings in her retail sales, that covers all of her expenses with a little bit of additional expense to cover any capital improvements that she needs. Her retail sales are coming in. It's looking like they're going to be about 2 to 3% higher than we expected, which is good. I think that this is her highest, and you can correct me wrong, Sherry, if you're on, but I believe this is going to be your highest year for retail sales. Is that correct?
Sherry.
She was, I saw her.
Yeah.
picture.
We should be right where we were last year, maybe a little bit more, but it's over our budget, what we budgeted for. So yes, we should be doing quite well on sales, so.
Ruth, the report is at the end, I think, of the September one. You put it there if you want to scroll down there.
Yep, just found it.
Are there any questions on any of the line items on there?
Bruce, can you blow it up a little bit more?
Yeah.
Wow.
That's a real good question.
There you go.
That's a really good question, Bob.
So you'll see that Sherry has a number of different types of revenues besides just the sales. She's bringing in revenue for all the different programs she's operating in the trainees that she has at the store. And some of those program trainees are probably more challenging than others, so her staff are really working very hard right now, especially with the CCS clients.
Like that family care that comes in, that's from the state, right?
Yeah, those were the clients that used to be our, long-term clients that we've had for years.
Yeah.
Unfortunately, the revenue from those programs is very small. And some of the numbers of clients are decreasing, and so we've had to really look at other program revenue and different clients, and she's really building up a clientele around behavioral health. So we're certainly very appreciative of Sherry's ability and her staff's ability to be flexible and take on different types of trainees.
I see she has 5 staff now.
5 staff. And if you were to ask Sherry, she would say she needs 5 more staff, probably.
I would say 1 for sure.
Yeah, and we have talked about that as the programs have changed and the clientele that we're serving has changed, the behaviors have changed, and the need to be one-on-one, it has increased, so that makes it more challenging.
Yes.
Sherry, do you have anything you want to add?
No, I don't. Thank you, Kelly and Wendy.
Certainly doing a good job of common sense.
Yes, very good job. Keep up the good work, Sherry.
Thank you. Thank you.
So where does the profit go back to? Does it stay in your cost center or
It drops into the HHS bucket at the end of the year.
at the end of the year?
Anything else, Wendy?
No, unless there's questions.
No more questions. Thank you.
Thank you.
Before we move on, can Deb and Teresa, can they hear in order, I just don't hear anything from them.
Yeah, they can't, they're on mute. Teresa, can you hear us okay?
I can hear fine.
Okay, Kelly.
We'll move on to director's report and the manager's narrative. Any questions about this report? No questions? We must have covered it very well then. Good. Project status report. I'll just go over a couple things to highlight. The first goal was our department policies to reflect trauma-informed care. I just wanted to highlight that we did send 24 staff, or direct service staff, through a 2-day training for motivational interviewing. That was last week. They were required to complete a evaluation of the training at the end of it, and they were wonderful feedback that we got. Nothing negative, and I was expecting to have a couple, but everyone had really positive feedback, and I'm looking forward to their implementation of the training, so that was great. Another thing we wanted to highlight was the purchase of the 5 fleet vehicles. We did get a quote from AF Motors on the 3rd of November. The quote was very high, and it was for Malibus, and the 2 Malibus would have eaten up more than 50% of what we had discussed.
How much?
More than 50% of, so the quote was only valid for 7 days. And we had to let them know by the 10th of November. Wendy and I did meet with Kyle, and we agreed that because of the increased cost, we didn't have time to bring it back to discuss that increased cost. So we turned down putting our name on the list. the vehicles were also a higher package than what we originally planned on. So, we're still waiting for vehicle availability and, we'll see what happens with the budget and go from there. But we didn't feel like that was a decision we should make without talking to the board first.
Board's choice.
Yes.
You just never know. No, just kidding. Yeah, that's what we thought, that with that cost, we should really make sure it's something everyone supports. And that was really the only big projects to highlight. Any questions?
Well, it's ironic from the standpoint. I think Kyle was gonna get his money out of the used ones pretty much to offset the new ones. So now that's all changed.
Yeah.
Yes, it has.
So we'll just kind of wait and see. We do know that our vehicles are heavily used. So we are looking forward to getting more vehicles, but they are being used.
What do you get for mileage? Have any idea?
I have no idea.
I can get that.
I think
for
the
you.
last time I pulled it, it was, I don't know when I pulled it, but yeah, I don't know if this is a number. So
Can you follow up on that maybe next month?
Mhm.
we could get that very easily.
Are you starting to run into any maintenance costs because of the
Yeah,
ages? of
tire
the vehicles?
Warranty tires, but we had a warranty issue with what,
one of the Malibus,
a
yeah.
whole new engine or was it?
Whole new
transmission? Engine.
Don't need a new vehicle for
No, brand new.
But it was warranty, so.
It was warranty. Thankfully, all the work that we've had done, it's been warranty.
Hmm.
We're just replacing tires now because they're wearing out.
You know, somebody in charge of checking oil and, you know, all that.
Mhm.
So where's it? Oh,
Oh, you're the auto mechanic.
Kind of.
Scheduler.
Schedule it. Yeah.
Madam Chair,
That,
That was Kyle, I think.
the mileage, I just pulled up the mileage report for them.
are you kidding me? How can you do
because it's bad.
that?
Google remembers my username and password for everything, so. Yeah, we got 32,000 on one, 25,000, 34,000, 35,000. And then 20,000. And then the Equinox, we have it 31,000. That's as of the end of October.
There's less than 30,000 miles on most of them,
Mhm.
or 40,000, whatever.
That's important.
Yeah, they're all under 40,000.
How the hell do we go through an engine then?
That's why it's under warranty.
Yeah.
I think it was 11.
Yeah.
Personally, we had a lot of trouble with that one time.
Yeah, so they get used considering we got them the end of 2020, right? So they,
2 years.
so. Any other questions on that?
Well, I do have a question on that, then. You're getting, I think in the budget, there's 10 cars. So these are the 5 you're gonna replace, you have 5 somewhere else, then?
We would
Second
be,
5 we didn't get.
yeah, second 5 we're still waiting for. Well, the second 5, but then the landfill gave us an Equinox. We've been waiting on the other 4. Kyle, I can't remember, were those supposed to come in 2021?
They were supposed to come in 2022. We took it to the committee in October of 21 because of the vehicle shortages that were going on. And we were hoping to be able to order them as soon as we could, but the ordering never opened up.
So that's the one that you just turned down because of the pricing.
Correct.
And they didn't have any, we did not get a pricing for the Equinoxes at the time, like what was going for Malibu.
I assume the Malibu has a less of a sticker shock, doesn't it?
I don't know, what do you think, Kyle? That was kind of a sticker shock.
Well, they were quoted for under $20,000 initially, October of last year, and then came back at about 26,000.
in 2021, and now they came back at 26.
Is the equinox would be higher though. wouldn't it?
Yeah.
Yeah.
So, when we talked with Kyle, we had talked about what was approved, and then it wouldn't be able to pay for those per vehicles. We're holding. Kyle, is there anything you wanted to add to that?
No,
Okay.
Anything else? Okay.
Okay. Excuse me, report of committee members, Aging Advisory Committee.
Donna was gonna give a quick update on her Aging Advisory Committee meeting from October 19th.
Yep, we met on October 19th and we reviewed the August and September program reports, including an update on the elder abuse and adult protection services, which Lauren Heitman provided to us. We reviewed our progress on the 2022-2024 aging plan, which we're required to do, and we did review that. We also discussed 8521 specialized transportation projects for the upcoming application, which we'll discuss a little bit later here. There is a public hearing on this scheduled for Wednesday, November 16th at 9 o'clock in the morning. And then there was a presentation by Sarah Peterson on the Dementia Care 101, which went over very well. She did a great job. And we did change the meeting date from December to January 18th of 2023. And we, of course, are always still looking for members for both the Aging Advisory Board and the ADRC Governing Board. That's my quick update. Any questions?
Any questions? No, no questions here. Thank you. Okay, you're still on, Donna, for the, excuse me, specialized transportation 8521 grant.
Yeah, so every year we have to apply for 8521 grant. And so we're in the process of doing that right now. We are, we have 3 projects that go a part of that grant. Right, this year, the grant amount is, Ruth, do you have that? Do you have that ready? That 85, there's 3 projects. We were awarded 92, where we're applying for $92,085. And then between that, we'll have our projects. So we have project 1, which is our transportation for work day for the work and daycare. I'm sorry, I thought this was. So project 1 for this grant is our transportation for work daycare. This is something we've been doing for quite some time. That's where we use our buses primarily, and we take people back and forth to the adult daycare as well as to Practical Sense. We primarily take people with disabilities, but we also use it for frail elderly as well. Our project 2 is medical and non-medical escort, paid and non-paid drivers or volunteers. This is our project where we are taking people back and forth to their doctor's appointments, but we've also incorporated rides to hospitals, such as the one that Bonnie did for the Veteran Services. We also take people to Madison for special events and so forth. So that's kind of a big project that we do to keep people to provide some transportation in Adams County. And then project 3 is a new one that we've developed. It's called Find Your Own Driver. Because of the lack of volunteers, we have decided that since people use their friends and family, that we would help compensate for that. And so we've actually gotten people to find their own drivers, and then we pay the passenger to pay their drivers. So it's less liability on us, and people are more comfortable with that, and they're actually helping out their relatives or friends or family members with gas and so forth that they were struggling with. This program is actually becoming very popular with our seniors, so we're hoping to see that one grow. And if you can move this up, Ruth. The projects, these are the expenses for the projects, that we've divided out. Our budget for this year is 148,302, and so we've divided out the grant revenue that we're expecting, our 20% minimum that our county match in there, and so we've broken even if we can do this. We are expecting more from family care, so that will help offset it if we do go above that 148,302. Any questions on that? There's nothing to be decided on this, by the way. We just need to have a discussion. I just need to make you guys aware of this. So are there any questions?
Anyone questions? Donna, on your find your own driver, can the driver contact you about getting reimbursed for somebody? Or
Sure,
does
that
it
in
have
fact,
to be-
that's how we get a lot of them. The drivers actually call us and say, hey, how can I sign my passenger up? Because I'm taking them to dialysis 3 times a week and I just am trying to do this on my own. Is there a way I can sign them up? So we just provide the paperwork and then we work with the passenger then, and the drivers as partners. So yes, either one can contact us.
Okay, thank you.
Good question.
Moving on. On the 2021 5310 vehicle grant, where are we with that?
Well, I just wanted to update you on this grant. This is our vehicle grant. So every year we apply, or at least every other year we apply for a new vehicle, a van or a bus. In 2021, which is cycle 45, we did apply for a vehicle. We paid our 20% down, which was $10,000, a little over $10,000. We did do everything we were supposed to do. We were awarded the grant, but over the last few months, we've been told that the vehicle's cost has just gone really high. And so the state is looking for ways to help offset that cost, but they've also told us that we may have to come up with the additional dollars. And what they've told us is that it's going to be anywhere between $5,000 and a little over $24,000. That's something that we were hesitant to just say, sure, we can do that, especially since it's from 2 years ago and we're looking that budget's already been done and gone. So they had a lot of feedback from other counties saying, wait a second, we can't do this in a 2-day notice or whatever they gave us last week. And it's come back that they're going to come and they're going to revise the grant agreements that we had in 2021, and they're going to be looking at new costs and so forth. And at that time, we will bring it back to the committee to let you see what they have come up with. And they are looking for money at the state level to help compensate for this, because it was a huge difference. Some of the vehicles went from 55,000 to 75,000 to 90,000. So the cost was huge for some of these vehicles. So they're not going to order the vehicles until they get an okay that either the county or the state can find additional funds to support that difference. And so I just want to make you guys aware of that. We are waiting for that grant agreement or amendment to see what we want to do with that, because it's, 5,000 is much different than 25,000. So just wanted to make you guys aware of that.
Well, maybe that's someplace the state can put those extra funds they don't know what to do with.
Yeah. Yeah, I was, and the thing about it is, this was a vehicle we ordered in 2021, expecting it. Well, actually in 2020, we're expecting it in 2021. They haven't even ordered it yet. We're now applying for a new grant. And, we're hesitant now, we're applying for this grant, and what the cost will be. We're hoping that they can stick with it. The problem is that we have to pay our 20% up front. And now we've had, money sitting there for quite some time. And we still don't have anything out of it. if we choose not to get the vehicle out of cycle 45, we will get our $10,000+ back. That was told to us, so we'll have to wait and see how it goes.
So we'll keep you guys posted. We certainly want the vehicle if we can afford the vehicle. Donna did have a vehicle that she was looking to and end its life cycle on, as soon as we got this, so I guess more to come.
Donna, is there some-
Like the county vehicles, these vehicles get used quite a bit too, and we depend on them to do a lot of transportation that we have in Adams, so the vehicles are very important.
Donna, is there someone that takes ownership of the questions and the project? Is there someone that you, I guess, where the buck stops in Madison?
Yeah, we work with Lori Jacobson and Nick Musa from the DOT, Department of Transportation.
And do they have enough authority to do anything? Or they just, keep updating you on the numbers?
I don't know if they have what their authority level is, but they are the ones who approve the grants and approve the who gets the dollar amounts. These are competitive grants, so not everybody gets awarded.
I think the other thing to note is that it wasn't just Adams going back and saying, whoa, we
No.
can't do this. Because originally
Yeah.
Donna felt that she had a 2-day turnaround about, can you do this? And if so, let us know by Friday. Most counties or entities that were given or awarded a vehicle pushback and said, are you kidding?
Yeah.
When you've already tied up 10,000 and now you're asking for another 5,000. 5,000 is a little bit more easily swallowed than 25,000. So I think that there most likely is gonna be some discussion at a much higher level. And hopefully we don't have to pay the 25,000.
Because,
Anything
the
else,
other thing
Donna?
is, pardon me?
Anything else?
Nope. No. I need to be quiet.
Okay, thank you, Donna. Please keep us informed on this.
I will.
Okay, is there anything else? Our next meeting is set for December 12th, 4 p.m. Is that okay with everyone? Yeah. Okay. Hearing nothing else, the meeting is now adjourned. And thank you all. Have a happy Thanksgiving.
You too.
You too, bye.
What?
It was Cody, he said you too, bye.
Okay, Cody.
All right.
Okay. Some very good questions, gentlemen.